Okay, everyone, welcome. We're going to get started. My name is Jay Hughley. I'm the interim director at the Center on Race and Social Problems. I bring readings on behalf of our center, the University of Pittsburgh, and the School of Social Work. Welcome to our CRISPcast, the first in a series of conversations on race in America. And the first few episodes will be focused on race and COVID-19. We're super excited for our guest today, Dean Thomas Lavista from Tulane University, School of Public Health and Tropical Medicine. To give you a little background on our center, our mission is to conduct and disseminate applied social science research on race, color, ethnicity, and their influences on the quality of life of all Americans. You can follow us on Twitter, on Facebook at PittCrisp. And sorry, I'm trying to share my screen with you here. And if you have fancy technology, you can take a picture or pull up your phone and use that QR code to go right to our website. If you are interested in continuing education units for the talk today, you will receive a follow-up email that will allow you to get those. If you have questions for Dean Lavista based on this talk, you can use the chat function to chat with us panelists, and we will relay questions in the Q&A time. Please indicate your name and location so we can shout you out when we review your question. And this broadcast will be recorded, and you will be sent a link as a participant to share later or watch later. So with no further ado, we're going to get started. I'm going to welcome my co-host and partner in crime, Dr. John Wallace, who is our senior fellow, faculty fellow for research and engagement here at the center. Dr. Wallace, how are you today?
I'm excellent and getting better. How about yourself, Jay?
I'm doing well.
Very good. All right, so I'm excited to have the opportunity to introduce my colleague and friend, Dr. Thomas Lavista. Tom was born and raised in the Brownsville section of Brooklyn, New York. He's a proud graduate of the University of Maryland, Eastern Shore, also a graduate of the University of Michigan, where he got his MA and PhD in sociology. From 1990 to 2016, Tom was a professor at the Bloomberg School of Public Health at Johns Hopkins. He was actually the first African-American to be promoted to the rank of full professor at Hopkins. In 2013, he was elected to the National Academy of Medicine. He has over 140 peer-reviewed journal publications, about 8 books. At Hopkins, he was the founding director of the Center for Health Disparity Solutions. Between 2016 and 18, he was the chairman and professor of the Department of Health Policy and Management at the Millikan Institute School of Public Health at George Washington University. And since 2018, Tom has been the Dean and Weatherhead Presidential Chair in Health Equity at the School of Public Health and Tropical Medicine at Tulane University, which is located in New Orleans. Little known fact, Tom pays the double bass, which is probably the reason he really went to New Orleans. And he won't absolutely embrace it, but the truth of the matter is he's a Steeler fan. Tom, take it away. You're muted. You're muted.
Okay, thank you for that introduction. I feel compelled to say that I am not a Steelers fan by imagination, and in fact, I'm a Baltimore Raven fan. But that was the point of that joke, I think. It's a pleasure to have an opportunity to address this audience on this topic of COVID-19, which the pandemic has really taken over everything pretty much in my life, and I think that's the case for most of us. I've just been appointed by the governor of Louisiana to chair his COVID-19 task force, where we're looking at how do we come through this pandemic, but not just come back and go back to normal, but come back and go to a new normal, a better normal. The normal here in Louisiana has been that every year we are in a race with Texas and Mississippi for who is the 50th state in terms of the least healthy state, who is the And sometimes we're 50th, sometimes we're 49th, sometimes we're 48th, but we're always in that battle with Mississippi and Texas. Currently we're 49th, and what we don't want to do when we come back out of this pandemic is go back to that. We want to come back to a healthier and more equitable state. And that's what the task force is trying to do. Some of what I'll talk about relates to the work of the task force, others, the work that we're doing here at Tulane, and others, just what we're doing here in the city of New Orleans. As I'm sure you all know, New Orleans has been one of the hot spots for COVID-19, and we've been heavily involved in addressing the outbreak down here in New Orleans. So first, let me start with a little bit of background on what this is. I think it's important to point out that viral outbreaks or disease outbreaks happen all the time. If you go to the World Health Organization's website, you'll see that there are multiple disease outbreaks every year happening all over the world. And in fact, every year in this country, really worldwide, we have an influenza outbreak that occurs. So these types of disease outbreaks are in no way unusual or uncommon. What's unusual about this outbreak is the scope of it. The fact that it's a pandemic, not just an epidemic. Pandemic meaning it's the entire world. And the fact that this is a pandemic and not just another epidemic is what makes this different. So this virus, and so a little background on what the virus is and the way that we need to think about it. I hear these terms being used interchangeably, and I think it's important that we kind of ferret out what this all means. So we talk about this as a novel coronavirus. Novel meaning new, and by new meaning not that the virus hasn't existed until now, because it has existed before 2019, but it's novel in that this is the first time that humans are being infected by this virus. This is a virus that has existed in animals for some time, but now it's affecting humans for the first time, and that occurred in 2019. The virus, the name of the virus is actually SARS-CoV-2. SARS-CoV-2. SARS is an abbreviation for severe acute respiratory syndrome. CoV meaning it's a coronavirus, and 2 meaning this is the second SARS virus that has hit, right? So that's the name of the virus. This virus is part of a family of viruses called coronaviruses. So when people say that this is the coronavirus, or some people in the Black community refer to it as the Rona, that is not accurate. Coronavirus, there is no such thing as coronavirus. In fact, there is a group of viruses that are all in the family of coronaviruses. And this virus is part of that family. So it's not sufficient to simply have a test that finds coronaviruses. It needs to be specific enough to detect which specific coronavirus we're talking about. And then, so we've been referring to the term COVID-19. COVID-19 is the disease that is caused by the SARS-CoV-2 virus, which is part of the family of coronaviruses. And COVID-19 is also an abbreviation. COVID meaning corona, virus, disease, 19 meaning 2019, which is when it first was detected in humans in Wuhan, China in December. So that's kind of the breakdown of what these terms mean and how they all fit together in the way that we should be thinking about it. We should be thinking about avoiding being exposed to the SARS-CoV-2 virus, because if you're exposed to SARS-CoV-2 virus, you're at risk for developing COVID-19 disease. And that virus is part of the coronavirus family. So the virus has spread extremely rapidly. The first cases were detected in late December, late November, early December. The first case in the United States was in February, and it's rapidly spread over these last few weeks, rapidly spread to be a worldwide pandemic. And now there is really no country on the planet that's not touched by this virus. In some cases, we have very little testing done, and there may be little awareness of the extent of the exposure. But because of the lack of testing and the fact that we don't yet have sufficiently adequate antibody testing, we don't know how many people have been infected by this virus, but we do know that it is a worldwide phenomenon. This chart shows confirmed cases. I last updated this on the 17th, but the pattern has not changed. This is showing the number of confirmed cases over time, and it shows this rapid increase beginning in March, and this increase has continued even now into May. This chart is just showing some of the countries. I picked out a few selected countries just to give you a sense of how this is playing out around the world. And remembering that this is still, these data are updated regularly. These are still from a few weeks ago. The United States became the country with the largest number of cases back in late March. And that pattern continues. And at this point, we now have more cases, more documented cases in the United States than the next two countries combined. So the outbreak has been particularly heavy in the United States. Now you can say, if you look at a chart like this is looking at total number of deaths by country. And of course, there's significant differences in the sizes of these countries, number of people in these countries. So France and Italy, Germany, Canada have many fewer residents than the United States. But it's also important to point out that China has about 5 times the population of the United States. So while it has about 5 times the population of the United States, the number of deaths in China has been infinitesimal compared to the number of deaths in the United States. Louisiana, the state where I am, is one of the states with that's been one of the hot spots. We now have over 25,000 documented cases in Louisiana. Over the last few weeks, we've found that we have actually flattened the curve. We have been on a plateau. The number of deaths has declined, and the number of hospitalizations has also significantly declined. While things were bad here, things never got quite as bad as we were projecting they could be. We have at the Tulane Hospital, we have 356 ventilators. We never had more than 253 of them in use at any one time. So we never reached our capacity. We were never overtopped here in any of the hospitals. And I believe we only had about 50 people total at the convention center where we set up a field hospital. So while things were bad here, I think that the response and the preparation for the outbreak here was actually pretty good and worked really well. And we never got overtopped, which we were concerned was going to happen. One of the biggest problems that we've had with this disease is that there really has not been a national policy response. Instead, states were left to fashion their own responses. And as a result, we have different states doing different things at different times. And this lack of a national coordinated response has led to, I was recently quoted on NPR as saying that we're headed for a macabre game of whack-a-mole. And I think that's right, that what's going to happen is that we'll have outbreaks in one part of the country, and as that outbreak begins to subside, we'll find the neighboring state will have an outbreak, and then once that subsides, we'll find that that state will reinfect the previous state. So there was a point here, Louisiana was unique in the southern states as the only state in the South that responded aggressively and early on to this pandemic. But we were surrounded by states that did not respond quickly. And in some cases, we had governors in our neighboring states that were outright hostile to the idea of doing anything to address it. Texas erected border patrol to try to keep people from Louisiana from going into Texas. And what we see now is that while the number of cases is dropping in Louisiana, the number of cases in Texas is going up. And at some point, we may need to turn those border patrols around in the other direction and stop people from Texas from coming into Louisiana and infecting our state, because some of these states have been very lax in their response. And we can expect, I think, outbreaks to occur in states like Texas and Alabama, Mississippi, and Arkansas, Georgia, and Florida, the states that surround us. Testing has been a huge problem, and it's been a huge problem here in Louisiana as well. We started early with the drive-up testing, which was a good solution for many people, but not an adequate solution for everyone. And when you look at the census tracts in New Orleans where the cases occurred, they occurred predominantly in the eastern part of the city, which is predominantly African American and low income. And people in the east, many of them did not have cars and could not drive up to the testing sites. The testing sites were not easily accessible to the east. And as a result, we found that the virus was spreading in that part of the city rapidly with little detection. We now have moved away from the drive-up. We've closed all the drive-up testing sites in New Orleans, and we now have mobile testing sites. So the vans going out into communities where people can walk up and get testing. And I think that was a good response and readjustment and strategy that has done a good job of being more equitable in terms of who could get tested here in New Orleans. And we're finding that the cases predominate in the New Orleans East area. At the federal level, since the federal government did not develop a national policy, did not really become active, and still hasn't been active in as active as it could be in increasing testing capacity. Another issue has been communications. But there's been muddled and communications coming out of the federal government. Early on, there was talk about the virus being a hoax. There is still talk coming out of the federal government about the origin of the virus. Early on, we had federal officials, including the Surgeon General, telling people not to wear masks, which was obviously not sound public health science behind telling people not to wear masks. The messaging gave the impression that young people were immune and it was only older people that was dying. That was never accurate, but that was information that was put out, and that gave younger people the impression that if you're in your 20s, that you're somehow immune from this disease. Untrue. And so if anyone's still harboring that belief, please rethink that. That is not the case. We also had a lot of ambivalence around the shelter-in-place orders. And so we got a lot of mixed messages from different parts of the federal government around whether or not we should shelter in place, and if so, how long should that be? And that a lot of what's happened and is still happening in terms of federal policy making is this dichotomy between the health of the population and the economy. And the attempt to weigh the benefits of addressing the economy versus addressing the public's health. And because of this, I think this is one of the reasons why the death toll in the United States has been so high. We've now topped 72,000 deaths in the United States. And I think it's fair to say that we're still early in this pandemic, and we can expect, unless there's dramatic change in national policy, we can expect that there'll be many more than 72,000 deaths. I would also comment about social distancing, that this terminology, social distancing, another example of, I think, bad public health messaging. We do not want social distancing. In fact, social distancing is the complete opposite of what we want to happen right now. What we want is for people to be physically distant. We need more social connection. We need more people to have more of a sense of community. So the term social distancing was a very unfortunate term. It now communicates because people have meaning for it. But social distancing actually means physical distancing. And what we need to do is ask people to stay physically distant, but stay socially connected. And it's through that social connection that we'll be looking out for each other, we'll be taking care of people in our communities, and that it'll maybe reduce the likelihood of hoarding and other forms of civil unrest. And of course, race is always a factor in much of what happens in this country and much of our policy making. The subtext of it is about race. And as we've seen, African Americans, and now we're learning Hispanics and Native Americans are disproportionately being impacted by this condition. So the question of where did the virus come from is something that comes up a lot. I would say, first of all, where the virus comes from is really not a relevant or important point right now. We need to deal with the problems that we're facing right now, which is how do we reduce the number of people that are infected? How do we ensure that when people are infected that they're able to get tested and they're able to get access to healthcare, and that we're able to provide them with the care necessary for them to recover from this infection. But one of my colleagues, Bob Gary, was part of a team that published this report on the origins of the SARS-CoV-2 virus. And I want to play a brief video of Bob talking about it, what they found in that study. So just bear with me for a second.
What we did in this study was we looked.
Okay.
What we did in this study was we looked to try to figure out, based on the genetics of the virus and what we knew about coronaviruses before this, where the virus might have come from. So one thing I can tell you is that this is not a bioweapon. Nobody made this virus in the laboratory. This is a product of nature. What we believe is that the virus, probably a long time ago, originated from a bat species, because there are coronaviruses of bats that are very similar to this new coronavirus, the SARS coronavirus 2. But there are other parts of the virus that look more like other animal coronaviruses. So what we believe is that this is a recombinant. So the virus combined from two different species to create a virus that is now infecting humans. Now, we don't know how long the virus was in humans. It could be just a few months, could be years, could be decades. But what we do know is that there are a few small changes that were made in the virus that allowed it to spread more rapidly. We know that the origin of this virus is different than the original SARS virus. That virus was actually a zoonosis. It's a disease that spreads from animals directly to humans. This virus definitely originated in animals, probably bats and some other animals too. You probably heard on the news talk about this spiny anteater that has some viruses that are similar. So what we think is that this virus is a recombinant. It probably came from a bat virus, plus perhaps one of these viruses from the pangolin. It recombined. The genetic material came together. And then it probably spread in humans for a while. We don't know how long. It could have been months, could have been decades of this virus spreading and evolving in some other animal or humans. And then finally, just that one little mutation that occurred that allowed it to spread more rapidly.
Bear with me 1 second while I get the slides back up. So while there's been a lot of talk about the virus starting being bioengineered and being, excuse me here.
Welcome to the show, which is still.
Okay, that transition wasn't as smooth as I intended for it to be. So, but anyway, while there's a lot of talk about the virus being a bioweapon, there isn't any evidence that that is the case. And even if it were, I think at this point, what we need to be doing is focusing on the fact that there are people being infected and dying right now, and that we need to spend our resources on addressing that issue at this point. And at some point down the line, I think we can turn our attention to whether or not the virus was bioengineered, which I don't think there's evidence to support that is the case. So early on, there was a lot of misinformation, and still a lot of misinformation being targeted to African Americans around this virus. And one of the early myths was that African Americans were immune from this virus, which was always fascinating to me, because there's no scientific evidence that there is such a thing as any virus that would only infect one racial or ethnic group. So that would not be a possibility. So as we now know, the virus, Idris Elba was one of the early celebrities to come out publicly and indicate that he had been infected with the virus. And then when looking at the death rate and, well, the proportion of deaths that have occurred, it's pretty clear, I think, at this point that that myth is inaccurate. In fact, when you look across the states, you see that in most states, African Americans are disproportionately impacted. So here is Louisiana, where African Americans are 59% of the deaths, while only 32% of the population of Louisiana. There's California, again, see higher proportion of African American deaths than there are African Americans in the state's population. Michigan, similar pattern. And if we look across some other communities, we see the consistent pattern in most cases where African Americans are disproportionately being impacted by COVID-19 deaths. So does the virus discriminate? I would say, yes, it does discriminate, but not in the way that it was thought early on when some were believing that African Americans were immune. It discriminates, but not in favor of African Americans. If anything, it discriminates against African Americans. So this is the chart that I put together showing the 24 states for which the race-specific data has been released and that I've been able to obtain. And I've plotted in green the percentage of African Americans in the state, and in blue, plotted the proportion of deaths in that state that are African American. As we see, the pattern generally shows that African Americans are disproportionately impacted, but that is not the case in every state. So here I've added a ratio. So this is just taking the percent African American living in the state, the percent African American deaths over the percent African Americans living in the state. So at the very high end, we have Wisconsin, and this number here, 4, is telling us that the proportion of African American deaths in Wisconsin is 4 times higher than the proportion of African Americans living in the state. So the African Americans in Wisconsin 4 times greater than was represented among the deaths, 4 times greater than the representation among the population. But on the other end of the spectrum, we see that there are several states where the proportion of African American deaths are actually lower than the proportion of African Americans living in that state. Arizona, Connecticut, Washington, Massachusetts, just to name a few. So this, I think, is important to point out because it's not uniformly the case that in every state and in every place, African Americans are disproportionately impacted, at least not at this point. It's also important to point this out because this suggests that it is unlikely that there is some genetic thing happening with African American that's producing the deaths and the higher number of deaths in most of these states. I should also point out that these data are very dependent on testing and testing rates. And in some of these states, we have very low testing rates. So the data is very incomplete. And since this is such a dynamic pandemic that's happening, whatever we say about data today may not be the case tomorrow because things are changing rapidly. But as of right now, we can show that there are some states where African Americans are not disproportionately impacted. However, in the majority of cases, they are. So here's a summary of the 24 states. So the average ratio is 1.54, and what that means is that on average, African Americans are 54% overrepresented among the deaths. So that is true on a national basis. We find that the state with the lowest ratio, Arizona, is 0.5, which means that African Americans is about 50% of the number of deaths is about half or 50% of what you would expect, given the number of African Americans living in Arizona. On the other end, you have the highest ratio, which is 4.1 in Wisconsin, that African Americans are 4.1 or 4 times more overrepresented among deaths than they are in the population. There were 17 states where African American deaths exceeded the percentage of African Americans in the state, but there are 7 states where the percentage of African American deaths is lower than the percentage of African Americans in the state. So there is complexity to this, and we should take heed of that complexity. what is coming out a lot, and I see it in the media, is the narrative that the reason that African Americans are being disproportionately impacted is because there are higher rates of chronic diseases among African Americans. This is that there are pre-existing racial disparities in African Americans having higher rates of diseases that we know increase the chances of death if you are infected. So this is hypertension, diabetes, asthma, COPD, cancer, a few other chronic, obesity, and a few other chronic conditions. It is likely that that's a part of the solution, of the explanation for the disproportionate burden on African Americans. But I hesitate, and I'm very resistant to lock in on any one solution, because it's unlikely that that one thing is the full answer. Because when you look at states, especially states in the South, we find that whites in the South have extremely high rates of these same conditions. Whites have extremely high rates of obesity, extremely high rates of hypertension and diabetes. And the disparity between Black and white Americans, especially here in the South, is not nearly great enough for that in and of itself to explain the disparity in COVID deaths. So that is probably a portion of the explanation, but that is not the full answer. There's more to it here. We've heard explanations about health behavior. I mean, the Surgeon General, African American himself, put out a message to African Americans that they need to stop smoking and drinking and exercise more. I think it's a valid statement to make. African Americans should smoke less, drink less, exercise more. I think it's also accurate to say that white Americans should smoke less, drink less, and exercise more. I think it's also accurate to say that Hispanic Americans should smoke less, drink less, and exercise more, that Asian Americans should smoke less, drink less, and exercise more, and Native Americans should smoke less, drink less, and exercise more. This is not a specifically African American issue. This is an issue for all Americans, and not being in good physical conditions, smoking and drinking, increases the risk of an adverse outcome if you are infected by this disease, but it is not a race-specific issue. Now, what is a little bit more race-specific is the distrust of government institutions. So when government comes out and tells you that you should shelter in place, you should stay at home, it tells you, give you confusing and mixed messages. On the one hand, you should wear a mask. On the other hand, you shouldn't wear a mask. You know, African Americans have distrust of the American government. And that distrust comes from a very real place. It comes from experiences, 401 years of experience of untrustworthy behavior that led to that distrust. So the distrust is there. The distrust makes sense. It comes from a very logical place. And we do need to combat that when we put out messaging. So the health communication messages need to be coming from trusted sources. It needs to be authoritative. It needs to be unambiguous. It needs to be clear. And then there's the acceptance of myths. And the myths, in some cases, were targeted to African Americans. And as a result, some African Americans did believe those myths about being immune, for example. And this has played a role in the disproportionate impact, most likely as well. But there's another set of issues that have not gotten as much attention, especially from the national policymakers. And these are the explanations on the other side of the screen. That African Americans are more likely to work in occupations that place them at risk. They're more likely to be working at the checkout line at a supermarket and still working. They're more likely to be the person working for Uber Eats and delivering food to people who are fortunate enough to have occupations that allow them to work at home on Zoom and still collect their full salary. So the fact is that, so if you look at New Orleans, for example, one of the early hotspots, the economy here is heavily dependent on tourism. African Americans disproportionately work in the tourist industry. We are an international destination. People from all over the world come here. African Americans more likely to interact with them because we're working in those occupations. The city, as is the rest of the country, is a racially segregated place. So if you work as a bartender at one of the bars in the French Quarter and you you become infected by interacting with one of the guests there, it's more likely the case that when you go home, you're going home to a segregated, predominantly Black community. Therefore, the people that are at greatest risk from being infected by that person is going to be other African Americans. And that segregation that we have in this country, I believe, has created an infrastructure that allowed the virus to spread in a racially specific way, which is why in some of the early cases we found have been among certain racial and ethnic groups. But then also there's a set of government policies that have created an infrastructure that creates fertile ground for this virus to spread, and in particular here in the South. So in the South, the states in the South, most of them are right-to-work states, which means that we don't have union protections. And the lack of union protections mean that unions are not there to protect workers and to advocate for workers and for safety of workers within their jobs. Most of the states in the South, with the exclusion of Louisiana, of course, and Kentucky, most of the states in the South has refused to expand Medicaid, which means that we have more uninsured people in the South than we otherwise would have. And of course, people that are uninsured, we know, are more likely to delay seeking care, even when they feel that they do need health care. And then finally, wages are artificially held down here in the South because these are right-to-work states. We have lower minimum wages here than we have in other parts of the country. And as a result, we have more people living in poverty in the South than we otherwise would have. And of course, financial resources is what you need to be able to mitigate the impact of the virus. So the reason that African Americans are disproportionately impacted, I do think, is some of the things that we're hearing about in the media, such as the chronic conditions, the health behaviors, the distrust and the myths, but we have to also look at these policy decisions that have been made over the decades that have created a community infrastructure that is just fertile ground for a pandemic like this. So I'm going to end by just talking about two things, some of the things that we're doing here at the Tulane School of Public Health and Tropical Medicine. We've been heavily involved in the response. We've had some of our staff and faculty and students working up for the mobile testing units, working for the drive-through units. You know, we have our students and faculty working with contact tracing. Many of us advising the governor, advising the mayor, and heavily involved in a response. One of the things that we have, and if you're interested in staying up on the most up-to-date information on COVID-19 disease, we've developed this tool here called the Tulane Outbreak Daily. This is a daily newsletter that we put out every afternoon, and this is up-to-date information on what's happened in that last 24-hour period around COVID-19. So if you want to stay up on this, this would be a good source. You can simply go to the website, tulaneoutbreakdaily.org, and just enter your email address onto the website, and you'll be added to the list, and you'll receive this daily briefing on new information around COVID-19. And also, we've recently launched a project called The Skin You're In, which is targeting African Americans for accurate and authoritative information around COVID-19 disease. This is using social media, this website. We're also doing street marketing here in New Orleans and in Baton Rouge. And we're looking at expanding this to other cities as well, where we're doing everything from putting up posters on the streets, putting posters in beauty parlors, barbershops, other places, food establishments that African Americans frequent a lot. But of course, there is a national social media campaign, and I'll just quickly go out here and just show you the website. The web address is TSYI, which is the initials for the project, The Skin You're In, tsyi.org, where you can get up-to-date information. On this site, we do have resources that you can access and that are available for download, articles about COVID-19, videos describing and explaining what's happening with COVID-19, featuring some of our faculty and student experts. We also have infographics that is available for download. You can download and use them in any way that you find appropriate to reach people with authoritative information about COVID-19. And then of course, if you want to connect with us, you can simply sign up to receive updates and also interact with us in our social media channels. So that is the end of my prepared remarks, and I'd be happy to answer any questions that any of you have about COVID-19 or anything that we're doing about it.
Thanks, Tom. That was great. We appreciate your comments. We have a question from William. He says, in the UK, there's similar overrepresentation of Black communities with the disease. What role does history of socioeconomic disparities play in relation to the current crisis?
Yeah, I think that's what I think that's the underlying issue. What's happening here is that when you have these pre-existing racial disparities and racial inequity, not only in healthcare but in economic status, occupation, education, political power, that when these disease outbreaks occur, other traumatic experiences like this happen. Hurricane Katrina was another example of that. You see that disproportionately people that are disadvantaged are impacted. And so I think that what the questioner is asking about in the UK is part and parcel of the problem that we're having here in the United States. Populations that are already disadvantaged politically and economically and in terms of their health status are disproportionately impacted when traumas occur.
We have a question from eBay here in University of Pittsburgh. And he says, many have suggested increasing investments in public health as a solution for addressing some of these disparities. From a policy perspective, what do you think that would look like, an increased investment in public health?
You said, now, give me the first part. You said investments in public health. Was that the question?
Yeah, how can investments in public health be leveraged to address these kinds of disparities in health outcomes and vulnerability to this kind of situation?
Sure. So there were investments made in public health. So I talked about the Tulane Outbreak Daily. So the backstory there is that the person that does that for us used to do it for the federal government. She worked first for the CIA and then for the NSA, where she was doing these daily outbreaks, this daily outbreak newsletter that was going to people in the intelligence community, people in public health professionals, and policymakers. And then when the Trump administration discovered that she's been doing this since the Bush administration. She did it throughout the Bush administration and throughout the Obama administration. And then once the Trump administration discovered that she was doing this, they asked her to stop. And then she resigned. And then when she resigned, I was able to hire her at Tulane to continue to do this work through the university. So this was part of the infrastructure that had been put in place by previous presidents. There was also the early warning teams that had been created by the Obama administration that were disbanded by the Trump administration. So these types of investments that we've created over the years are investments that in some cases were already existing and had been disbanded. So that was the first thing. But if you're asking the question, what would an investment in public health look like? I think the simplest, the lowest hanging fruit is that in this country, we have an employer-based health system. In other words, access to healthcare is determined by health insurance, and access to health insurance is determined largely by employment. And it fascinates me that Americans accept that and don't find that to be an unacceptable situation. Nowhere else on the planet do we tie access to healthcare to employment. And I think this pandemic shows that tying employment to healthcare is folly. Because if you have great health insurance and you get on the elevator with someone who is uninsured and who has a viral disease and is infectious, your health insurance card is not going to protect you. So for the good of the country, for the good of all of us, we need to cover all of us. And we need to disentangle access to healthcare from employment so that we can have more people that are employed. The largest employers will have maybe 1 million people in their insurance risk pool. If you count employees plus their families, maybe 1 million, maybe 2. If we had one risk pool of 327 million Americans, we would be able to drive down healthcare costs because there were so many people in that risk pool, and we would have a more efficient system. We would cover everyone, and we would address, I think, the easiest and simplest part of the issue of addressing the public health inadequacies is there.
So Tom, I have a question. So we see that a place like New Orleans, for example, which is an international city, right? You have the Mardi Gras effect, people coming from all over the world. What about places, even like Pittsburgh, for example, where we do not have a lot of folks because of our racial residential segregation, frankly, the interactions between folks coming from Europe and China, where things first began, the interaction is actually relatively low. And so is it possible where we see places where African-Americans are not overrepresented, that segregation could in fact represent a kind of strange protective effect?
So in theory, yeah, that could be the case. I mean, so it's just this, I gave the scenario, right, of this visitor coming from another country, going to the French Quarter, interacting with a Black bartender, right? It could have just as well have been a white bartender. And I guess it could have gone in another direction as well. So in theory, sure. But ultimately, this virus is spread so easily that racial segregation is not going to stop it from spreading throughout all racial and ethnic groups. It's just a matter of time. And so my biggest concern actually is not the cities. My biggest so Pittsburgh has the medical care infrastructure to manage an outbreak. If what happened in New Orleans happens in Pittsburgh, you've got several major national health systems located there. You know, we have 356 ventilators here at Tulane. You've probably got double that number at UPMC. I mean, so I think you've probably got double our population too in Pittsburgh. So I think I'm not worried about places like that. I'm worried about the rural areas, which are predominantly white. I'm worried about the rural areas because we put prisons in rural areas to create jobs. And a prison is a perfect place for an infectious disease to just decimate a population. And of course, the workers in those prisons are disproportionately going to be people who live in the communities that surround the prisons. And in those counties, you're going to find a county with no hospital at all. The next county over maybe has a hospital with no ICU. So that means no ventilators. And then 2 counties over, maybe there's a hospital with 1 or 2 ventilators. How are those hospitals, how are those communities going to be able to manage an outbreak? Those are the things that I'm far more worried about, even than a city the size of Pittsburgh.
Dean LaVeist, we had a couple questions from people, Maria at Smith College and Beth Mulvaney at the University of Pittsburgh, that relate to reopenings that are happening. And the larger question is, how can that be done in any kind of safe capacity? Do you have recommendations?
Yeah.
And then for communities of color, people that are trying to use that to access mental health services, substance abuse services, things they wouldn't have been able to do otherwise. Have you heard of ways that people are able to do that safely or thinking about doing that safely?
Yeah, so I'm very much involved in some of those discussions, both at this university, but also in helping advise the state, the governor, and the city about some of these issues. So there's a lot of conversation about how we do this safely. So I'll give you my flip answer, which is sort of semi-serious, but not entirely joking, which is that you look at a state like Georgia, which has recently reopened. Georgia has had an increase in cases over the last 2 weeks, and they're reopening, right? And they reopened first by opening beauty parlors, barbershops, bowling alleys, tattoo parlors, right? I'm sure many of you saw the pictures of people at the mall standing in line to buy Air Jordans, not wearing masks, and also not observing 6 feet of physical distancing. My flip answer there is, if I lived in Georgia, I would not come out of my house until they opened up the tanning salons and the country clubs. And once the tanning salons and the country clubs open, I would say, okay, it's safe to come out now.
What you trying to say? What you trying to say, Tom?
I think I said it, and that's my flip, only semi-joking response to that. But yeah, there are ways. So I was recently consulting with the restaurant industry here in Louisiana, and also with the gambling industry, believe it or not, the gaming industry, about how they can reopen safely. And I do think there are some businesses that can open and put precautions in place to stay safe. So for example, what we told the casinos is that you have to have a questionnaire. You ask every patron about their symptoms. You take temperature for everyone. This is not 100%, but this will certainly dramatically reduce the risk. And you don't let anyone enter the building who's got a temperature, an elevated temperature, or who report that they have had any of the symptoms that we know to be associated with COVID-19 disease. You require them to wash their hands before they enter the building, and wear a mask at all times while they're in the casino. You allow them to participate in only games that will allow them to have appropriate physical distance, so that you couldn't have, poker players sitting, a few feet apart. They have to be spread out enough that they're not, that they're far enough apart from each other, and that they're wearing masks, which I think would help you in your poker game. Certainly would help me in poker, to be able to have my face covered. The staff shouldn't be allowed to enter the building without also being checked. And then you have to have paid leave for workers, because you don't want to disincentivize workers for taking off if they feel they have symptoms, which could be another problem. If you don't get paid if you don't work, then people are going to work, even if they're feeling sick. So we need to tell people that, no, if you take off, you're going to still get paid. These are all strategies that can work. I mean, I see a lot of stores that are open now. They're putting up plexiglass. That's one thing that's always existed in many of the Black communities. Plexiglass between the patrons and the cashiers. I think that is protective, and I think having that kind of a system in place is helpful. So on a case-by-case basis, I think you can look at different businesses and find strategies that can be effective.
Hey, Tom, so question. The African-American faith community has been hit particularly hard, it appears, particularly in Detroit, New York, and elsewhere. What can we do, or what should be done to mobilize this infrastructure? Because the churches and so forth are ubiquitous in our communities. What can be done to mobilize this infrastructure to help address the issue of COVID-19 in the Black community?
Yeah, this is a great question. Because this is kind of what we're doing with the Skin Your In project. Is we're starting here in New Orleans, but we really want to blow this up to a national thing. And I think churches could be really powerful partners, because for major portions of the community, churches are credible voices. Churches do have trust, and so if you're hearing from the church, wear a mask, wash your hands, those types of messages, I think that will have sway with a large portion of the population. So I think pastors can become educated about the disease, understand what are the important messages to bring, and I think pastors are excellent messengers from that standpoint. I think churches also, the church building can be an asset. So if you need to have testing sites, churches are strategically located in communities where people can access them. And I think, and churches often have the physical ability, depending on the size of the building, to be able to be part of that infrastructure to help with testing. So I do think there are things churches can do to be a part of the solution.
All right, Dean LaVeist, I have a question from Deshawn, one of the doc students here at Pitt, and this is coming from Twitter. How can we combat COVID-19 disparities among African Americans without engaging in anti-Blackness and reinforcing white supremacy? And this is really related to people blaming the behaviors and saying that it's racial based on people's behaviors.
Can you repeat the question? How can we combat?
There's a lot of dialogue out there that's being used to blame Black people for the disparities and saying it's Black behaviors that are, you touched on this a little bit in the slides, but how do we combat that as we go forward and interact as researchers, public servants, and citizens?
So I can say what my strategy is. I mean, I don't know that this is the strategy or if it's even the right strategy. My strategy is to combat it with truth, to say that, yeah, there are these racial disparities that pre-existed COVID-19. And those disparities are part of what's happening here. The fact that, obesity, we know, is one of the underlying risk factors that if you're infected, your risk of death is increased if we have obesity. And we know that African Americans disproportionately have obesity. So yeah, that's real. But I don't think that that's the full solution, the full answer to what's happening and why African Americans are being disproportionately burdened. You have to also look at the other explanations. And I talked about occupation. I talked about policies that disadvantage African Americans. And you have to talk about all of that. But you can't deny the truth too. I mean, so some of the truth does not reflect positively on African Americans. I talked about people standing in line to get Air Jordans in Atlanta. That was African Americans. We talked about the churches. When we had the shelter-in-place order here in Louisiana, there were 2 churches that defied the order and continued to have services. These were Black churches. So that's real, and I don't think that we gain anything by not acknowledging the truth. The truth is that we did have some African Americans that were acting in very irresponsible ways, and that placed people at risk. We need to call that out because that's real. But we also have to call out the states that have the right to work states that don't have unions to help support workers, or low minimum wages, or states that refuse to expand Medicaid and left people without access to health care. We have to call that out too. That's my strategy. Call all of it out.
So Tom, last question. So our kids have going to lose about 3 months of schooling. Many of them are already behind.
Yes.
But it's interesting, right? The research suggests that the disease doesn't impact children as much as it does folks who are older. So as we're thinking about children's activities in the summer, what should we be doing? Because I don't think we can afford to just let this summer pass and our kids literally lose 6 months of their education this year.
Exactly. We're getting some new reports now, still early, that children who have been infected are developing severe symptoms, not the same symptoms as adults, but there seems to be a syndrome that we're starting to recognize in children as well. So and I talked earlier about the federal government's messaging and how it's been problematic, is that it's put out this narrative that this is a problem only for older people, and that has never been true. And for some reason, that's kind of what's been put out there. Young people are also at risk, and now we're learning that young children, school-aged children, are also at risk. And we're only finding it out now because the things that the symptoms that they're reporting are different than the COVID symptoms that we've had having adults. So we're only now recognizing those symptoms as being tied to COVID. So now, but the question was really, what can we do with the children? I think, unfortunately, I think that the best solution is going to be to find online solutions to allow children to continue their education as best as we can online, because I still think that we don't want people to be gathering, and that's what we're going to have to do, I think. There's a lot of talk about this virus, the pandemic dying off when it gets warm. And that's because we know that the influenza virus, which is a very different virus than this one, the influenza virus does not do well in warm weather, which is why flu season starts to decline when it gets warm. It never goes away, by the way, so you can always acquire the flu, even in the dead of the summer, but the virus gets weaker in the summer, and there was some thought that that might be the case with COVID-19. I never thought so, because I said, well, Louisiana, we've had a number of days of 80 degrees or higher here in Louisiana, and we've been one of the hot spots. So weather, I don't think is going to be the thing. It is not the case. I think that after we get through these waves, we'll have a number of waves around the country that'll happen. They'll still be happening in the summer. They're not going to stop. We're not going to be finished with this by August. That's not going to happen. We'll subside in some places. Then we'll get spikes in other places. And then the time that we really need to be thinking about is when influenza season hits again, which is in around October. When that happens, we're going to have the SARS-2 virus and influenza virus hitting at the same time. And we know that there'll be more competition for use of ICUs and ventilators, because that'll be another drain on the healthcare system. So the fall is a time that I'm not looking forward to.
Great.
I hope I answered that question, but anyway.
You're muted, Jake.
Dean LaVeist, thanks so much for sharing everything that you have shared with us today. We're getting a lot of positive feedback online, and I'm sorry we can't answer or pose everyone's questions. We're getting so many, but thank you all for joining us today. I do want to highlight the fact that we have our next talk scheduled already. Our next Cast will be Wednesday, May 20th, when we speak to Professor Dr. Richard Lee from University of Minnesota about xenophobia and strategies to support the Asian American communities nationally, but also worldwide. So thank you for joining us. Please follow us on social media. We will send out a video of the broadcast to everyone that attended today. And stay tuned for more Cast. Be safe and be well out there. Thanks.
Thanks, Tom. Appreciate it, man.
Peace.